on the live webinar on Dasatinib. Today we are going to discuss managing blood cancer with TKIs. As we know that during COVID-19 lockdown and again unlocking and living with COVID-19 pandemic and living the new normal life, we all are gathered for the CME on the Zoom meeting. For today's talk, we have Dr. Ganesh, Dr. Prabhu, and Dr. Deepak. We are having the session on the blood cancer and TKI management, where Dr. Ganesh is going to moderate, and he is going to have the first speech on treatment guidelines for managing CML, NCCN 2020 and ELN guidelines 2020. As everyone knows, Dr. Ganesh, who is a senior consultant and head at Department of Hematology and BMT at Yashoda Hospital, Hyderabad. He has done his fellowship in leukemia and BMT and special training in lymphoma from University of British Columbia, Canada. Also, along with that, the postdoctoral fellowship in bone marrow transplantation at Tata Medical Center, Kolkata. For his clinical expertise, he is visiting to the Department of Hematology, VU University Medical Center, Amsterdam, Netherlands, as well as the Department of Stem Cell Transplantation, University of Düsseldorf, Germany. He is having the membership of the national and international societies for hematology, blood and bone marrow transplantation. I invite Dr. Ganesh to coordinate today's session and introduce the subsequent speaker and take the question and answer. Over to Dr. Ganesh.
Yes, thank you, Dr. Kunal. Good evening, everybody. I hope all of you are safe and being healthy. I hope my my screen is visible.
Yes, your screen is visible. Make it the full screen. Yes, yeah, now it's visible.
So I also hope and pray you grow, you gain strength with the coming times, and keep yourself safe. So today's webinar is thanks to Panacea Biotech for bringing us together for this wonderful academic session. And even though of late there has been a huge surge of webinars, particularly in the field of CML, thanks to the expiration of the patent for the second generation TKIs across the mostly North America and Europe. But I was wondering, and when I was going through this topic again, CML is a disease which continues to amaze us, no matter how repeatedly we keep on going through it. And I am sure me and my distinguished speakers for today's webinar, Dr. Deepak Charles, who is a senior consultant hematologist and a transplant physician at Aster Medicity, Kochi, and Dr. Prabhu, who is a senior consultant hematologist and a transplant physician at Apollo Hospital, Chennai, will bring a lot of new things to the audience happening in the field of CML. So my brief talk before I keep the ball rolling in the field of CML across this forum is the treatment guidelines for managing CML with emphasis on ELN 2020 guidelines, and also I will briefly put few slides on NCCN recommendations which has come just last month. So coming to the ELN guidelines, and I'm sure, and most of us follow the ELN guidelines in most of our leukemia management, be it AML or CML. So ELN has recently published these 2020 recommendations for CML management. This is a review article published in Leukemia this year, February. So the major emphasis of this article is a change in the strategy for managing CML, which is going to give us a better chance of not only just long-term, good survival, but also a chance of a new therapeutic goal, which is on the horizon, that is treatment-free remission. And then this treatment-free remission or TFR is not a new concept, and it has been existent since almost more than a decade now, since the first paper of TFR came in 2010. So it's for the Western Hemisphere, it's a established concept, and for us, we are slowly adapting to this new therapeutic goal. So these are the major changes. I just, for the sake of understanding, put ALN 2013 versus ALN 2020. What are the major, the highlights of ALN 2020? With regard to diagnostic workup, the definitions of all the different phases of CML remains the same. But most important here is, so when a patient has failed 2 TKIs, resistant to TKIs, you can see on the right, box, or emergence of additional chromosomal abnormalities raises a concerns for progressive disease. And as per the new guidelines, this may be a criteria for more aggressive curative intent therapy like allogenic stem cell transplant in such subset of patients. Again, with regard to the prognostic scores, there had been number of prognostic scores which most of us are used to using, but then ELN 2020 emphasizes mostly on this ELTS score, so UTOS long-term survival score, which not only because overall survival across the CML has been quite good. We have almost achieved a good milestone in terms of achieving a good overall survival. Most of our patients, barring few 10 to 20%, progressive disease or advanced phase patients. So then the next important parameter is leukemia related death, because once the overall survival remains the same, what is important is that the patients dying because of the various either progression or resistance or subsequent exhaustion of the normal hematopoietic stem cells, the leukemia related death is an important parameter. And then across previous prognostic scores, it used to be not variable across the groups, but this is ELTS score highlights a better disease related morbidity as well as mortality in this score. So also the panel recommends that the additional chromosomal abnormalities, more emphasis on that, and categorizing these patients as high risk patients, because prognosis may vary in these patients, and these patients are more vulnerable to progress to the subsequent accelerated phase or blastic phase in large majority of patients. So also the most important thing is that the panel agrees that the treatment-free remission is a new significant goal in CML management and has defined various criteria requirements for achievement of TFR. So coming to a subset of patients like pregnancy and parenting, for males taking various first and second generation TKIs and subsequently having offsprings, there is not much of a teratogenicity to their offsprings, because if the males are on TKIs and when they undergo the fatherhood, whereas for women, management of CML during pregnancy has been specifically emphasized, and there are different criteria, and this particular subset TFR may be a very viable and important goal, because while in our experience, many of the women who are on TKI who subsequently conceives and have a normal child, but still there is a concern of possible teratogenicity of various TKIs in females. So the key highlights, as I mentioned earlier, the UTOS score, there is a very easily available online calculator which you can grow, and then as I mentioned earlier, you can see across the previous so-called score, the mortality related to the CML as a whole was not very different across the groups, but you can see the leukemia related death in as per the ELTS for low risk is 2%, intermediate 5%, and high risk is 12%, is significantly high. Again, as highlighted earlier, the panel recommends classifying additional chromosomal abnormalities at diagnosis and taking these additional chromosomal abnormalities into consideration for labeling these patients as high-risk patients and subsequently devising the TKI strategy upfront in such subset of patients. Regarding various nomenclatures, complete molecular response term should be avoided. Better to use molecularly undetectable leukemia or deep molecular response. And there is a specific emphasis on generics, because generics has been not only the vital the pillar for CML management in developing countries like India, but generics have also been a major treatment factor across North America and Europe. So there is a specific focus on generics, and then they have mentioned that if the patient is on generic and is able to achieve the various criteria, they should continue the generics as long the patient achieves various milestones. Now, as I mentioned earlier, TFR is a new significant goal for CML management, and when it comes to TFR, particularly in India, the epidemiology of CML is such that our patients are at least 10 years younger than the Western population. TFR is a more realistic goal in developing countries like India. So with regard to that, my subsequent speakers are going to cover all the studies with regard to first and second generation TKIs in afferent CML CP. But just a brief run over of these trials. You can see the landmark IRIS trial, which has changed the landscape of CML management by introduction of Imatinib as the first targeted drug for any cancer, for that matter hematological cancer. And you can see the survival, the curves are comparable to the normal healthy counterparts. Now coming to second generation TKIs, Ernest trial as well as Dasatinib trial, the second generation Nilotinib, Dasatinib, you can see the significant earlier achievement of these milestones, the various molecular milestones when the patient is subjected to afferent second generation TKIs. And this is very important, as highlighted here. You can see those achieving the early molecular milestone, like 3-month complete cytogenetic response, those achieving this milestone versus those not achieving. Long run, you can see in both the slides, the overall survival and event-free survival drastically different. Those achieving these milestones early have a statistically significant superior overall survival as well as event-free survival, and that is very important in terms of long-term CML management. So as a hematologist, it is our strategy. We are trained, and we are this particular attire is imbibed in us right from our training. In a fight, hit first and hit hard. So that is particularly applicable even in the field of CML. So the one which is most potent, which gives you the best chances of various therapeutic milestones with afferent robust molecule compared to second generation versus first generation, that should be applied first. Now this is again the both North America as well as European Medical Agency has approved all second generation TKIs afferent. So TFR, as we all know, more than 80% recurrences occur within first 6 months after stocking. So stocking the TKI, whether first generation or second generation. That's why close monitoring during first 6 months is very essential. And the loss of major molecular response is relatively uncommon after the patient is off the drug beyond 1 year. So coming to second generation TKIs, the TFR rate with Imatinib is about 30 to 40%, and with Dasatinib, Nilotinib, it is not inferior, it is equally 40 to 50%, similar to Imatinib. Again, the most important factor of TFR is the duration of durable or deep molecular remission, which is the most important factor. And as I mentioned earlier, this TFR is a very, very important goal, particularly for our subset of patients, because I'm sure all of you will agree with me that we have patients in their 20s, 30s, 40s of CML CP. So for them, the first question when a clinician breaks the news that the patient is suffering with, even though it is a manageable blood cancer, but blood cancer, the word blood cancer is quite terrifying. And the next question comes, doctor, how long I'm going to continue the medicine? Is the disease curable or not? The moment you tell them or convey them that this is a lifelong medicine, most of their morale is down. And then that fear of impending disease progression or fear of, the blood cancer burning inside, that always keeps them worrisome. So, when you, with these therapeutic goals, when you convey them that there is still 50% chance that you may be off the drug after 5, 6, 7, 8 years, whatever duration of time. And if you are able to achieve the various milestones, that's a big relief for most of the patients. Now, these are the various TKI discontinuation recommendation as per the ELN 2020. The mandatory criteria, it has to be CML-CP. The patient should be willing to continue stringent monitoring at least for first 6 months, 1 year, and willing to accept the fact that 50% of the time the disease is going to come back off TKI and has to continue TKI subsequently for lifelong. Access to high quality quantitative PCR. So first 6 months, monthly PCR, that may, the cost of monthly PCR may be little transiently short term, may be higher than the cost of continuing TKI. The patient and the family has to agree to these specific requisites before you plan the TFR. Again, minimal, when the typical transcripts and duration of TKI at least 5 years. With new generation, second generation TKIs, this is little lower, at least 4 years of TKI therapy, and duration of deep molecular response, that is MR4 or better, at least for 2 years. And then optimal is duration of TKI 5 years, duration of DMR 3 years, and duration of DMR that is MR 4.5 2 years. So with this, again, which is the most important subset, which is going to, for whom TFR is a realistic and a very important goal. So as the younger patients with low intermediate risk disease or women of reproductive age group, these are the patients for whom TFR is a very, very vital therapeutic goal. So again, just for the sake of achieving TFR, change from second to first generation TKI is not acceptable unless and until patient does fulfill the criteria for not achieving various therapeutic milestones. Now, this is a very important paper published in Blood Advances this year. This is a paper where the consensus opinion from more than 100 hematologists, eminent hematologists from Europe were taken, and this is an expert opinion. So about their choice of the TKI of their choice with regard to various age groups and various risk stratification status of CML. You can see most of them. So the red bar is Imatinib, blue bar is Nilotinib, and green bar is Dasatinib. You can see for younger patients, 18 to 40 years, you can see most of them have preferred second generation TKIs. Again, coming to 41 to 65 years, because of higher cardiovascular morbidity with second generation TKIs, they have the opinion is equivocal. The bar A is low risk group and bar B is intermediate and high risk group. So for elderly people, of course, because of the higher cardiovascular comorbidities with regard to second generation TKIs, they have preferred Imatinib as first line in low risk group. Whereas intermediate and high risk group, you can see for younger patients less than 65 years, most of them have opted for second generation TKIs. Whereas for old population, again, up to say 8 years, they have opted for again second generation TKI in intermediate and high risk group. So this is again just a brief review of NCCN guidelines. You can see again NCCN guidelines recommend the TKI of choice based on the risk score, various risk scores, mostly the ELTS risk score. So intermediate and high risk score, the preferred regimen you can see is second generation TKI, Dasatinib, Nilotinib, and Bosutinib. So this is again, I'm sorry the slide is getting little stretched, but this is one of the charts which can also help us in devising the TKI of our choice based on the underlying patient age and comorbidities. For example, somebody has pleuropericardial or pulmonary issues, better to avoid Dasatinib. Somebody who has uncontrolled diabetes or cardio-cerebrovascular issues, use Nilotinib with caution. Again, hepatic impairment or hepatic disease, CLD patients, dose reduce Bosutinib or try to avoid Bosutinib. Renal impairment, dose reduce Imatinib or use Imatinib with caution. So again, second line TKIs, after the failure of first line TKI, there are, I'm sure Deepak and Dr. Prabhu is going to cover this in length. So treatment beyond second line, one of the most important thing highlighted in ELN 2020 is those having failed two TKIs, this should be seriously taken for consideration of allogenic stem cell transplant if the patient is young, fit, and has a suitable donor. So to conclude, goal of TKI and CML is not only just improving overall survival. We have at par achieved this milestone with various first generation as well as second generation TKIs, but to maximize the therapeutic goal of TFR, better prognostic scores are coming up, and with ELTS, this can actually predict better leukemia related mortality and can give us realistic prognostication of the disease impact in overall patients' disease course. Generic TKI is equally cost effective, and this has been appropriately elaborated in the ELN 2020. So genetic as guide for appropriate TKI selection to maximize deeper molecular response and thereby achieving the goal of treatment-free remission. So, and also ELN 2020 in particular gives various criteria which can help us planning TFR in the most suitable patients in our day-to-day practice. So with that, I thank, and I hope everybody keeps safe and stay healthy in these testing times. I think what we will do, we will take all the questions at the end of the all three sessions during as well as after the panel discussion. Now I will invite Dr. Deepak Charles to present his topic. Thank you.
Shall I share my screen?
Yes, please.
Hello. So good evening again. So what I'll be dealing with in the next 20 minutes or so is regarding how to select the TKIs and how to make decisions regarding monitoring the therapy. So I'll go about my presentation with the following headings. One is the TKIs. What are the TKIs available in the management of CML? How do we select this and how do we monitor them during the treatment? And we'll end up with one case which we discuss. So I'll just give a hint of the case which was there with us for a 1 year period. This was a young male who presented with priapism with no palpable spleen on presentation. He was referred from outside with the WBC count of 4 lakhs, and the smear was suggestive of CML with 4% basophils. The marrow was suggestive of a CML chronic phase, and there was a conventional chromosomal abnormality with an E13A2 transcript. The SOCAL risk score was low, and he was started on Imatinib 400 mg once a day. He attained a complete hematological response in 4 weeks' time, and the 3-month response was within the ELN stipulated less than 10% of 2.2%. But at 6 months of therapy, his qPCR was around 4.12, which is a warning sign. So I'll stop it here and continue with my talk. So the available TKIs for us, we can generate four categories. One, the first generation is the classical Imatinib. Second generation, we have 4 choices: Dasatinib, Nilotinib, and Bosutinib, which is available with us, and Dasatinib, which is only available in South Korea and studied mainly in the Asian population. The third generation TKI is Ponatinib, and we have a 4th generation TKI, which is a slightly different mechanism of action as compared to others. It's an allosteric inhibitor. So this slide just mentions the activity of BCR-ABL inhibitors in the various tyrosine kinase domains. So you can see that BCR-ABL is universally inhibited by the 5 available TKIs. But this slide is important in the sense you can see that apart from the BCR-ABL, there are other tyrosine kinases which are inhibited, and that depends that defines the toxicities as well as the therapeutic spectrum in which these TKIs can be applied. So ponatinib has the maximum spectrum among the available TKIs. So imatinib classically with the BCR-ABL, the c-KIT, and the PDGFR alpha or beta. Now coming to individual TKIs, we have imatinib, which was the conventional one, which was initially used into treatment as the second-line treatment in 2001, and then adapted into the first-line treatment. So it acts by attaching to the P loop or the BCR-ABL ATP binding site in the BCR-ABL oncoprotein and inhibits proliferation and induces apoptosis. So this was a classical IRIS trial, which the landmark trial showed the effect of imatinib on attaining a major cytogenetic response as compared to the interferon combination therapy. So this dose of 400 milligram of imatinib revolutionized CML treatment by transforming a fatal cancer into a chronic disease. I'll not go into the details of this, but what is important here is that now we have imatinib generics. So there was always a concern whether generics are equivalent to the innovators, and it has been proven beyond doubt in various studies at various sites that the efficacy as well as safety of generic imatinib is comparable to the innovators. The problem with imatinib is, or any TKI, is the development of resistance. So there are several mechanisms of resistance. One is the BCR-ABL dependent one, the other one is independent. So the dependent mechanisms are kinase domain mutations in the ABL or overamplifications or overexpression of the proteins. The BCR-ABL independent mechanisms are the multi-drug efflux proteins and overexpression of SRC-related kinases. One thing which is important here is the presence of the quiescent stem cells. It is known that the TKIs do not mainly target quiescent stem cells, and that may lead to the persistence and the recurrence of the disease later. Coming to the second generation TKIs, nilotinib is a structural analog of imatinib. It's almost 50 times more potent than imatinib. It has important in that it inhibits several imatinib resistant BCR-ABL mutants. The dosage adapted is 300 milligram twice a day, the first line, and 400 milligram twice a day in the second line, but most of the time this dose is not tolerated. Second line dose may not be tolerated. The most dose limiting factor here is the advent of the cardiovascular side effects, which occur in about 20 to 30% of patients over a 10-year follow-up period. And it is supposed to be dose related so that reduction of doses may tide over this to a certain extent. It is contraindicated in patients who have coronary artery disease, cerebral vascular accidents, peripheral occlusive arterial diseases, and past history of pancreatitis. And it should be used with caution in patients with hypertension, uncontrolled diabetes, and hypercholesteremia. Bosutinib, which is among the TKIs or the second generation TKIs, which has a lesser follow-up data, but it is more potent than imatinib. The dosage is once a day, 400 milligram in the first line and 500 milligram in the second line. It again attains higher rates of EMR and MMR as compared to imatinib. The advantage of bosutinib as compared to many other TKIs is that the side effect spectrum is different, and most of the side effects are the gastrointestinal adverse effects, especially in the form of diarrhea, which is seen in around 30 to 40% of patients with mild hepatic derangements. Redotinib I just mentioned because it's available in South Korea. It's a second generation TKI, structurally similar to nilotinib, and the dosage is also similar to nilotinib, and it causes transaminitis. Ponatinib is the third generation TKI, is approved for patients with the BCR-ABL T315I mutation and for patients with CML resistant to 2 or more TKIs. The FDA approved dose of ponatinib is just 45 milligram once a day, but the problem with this dose, and it even led to the temporary discontinuation of the drug, was the cardiovascular toxicity, which is seen in around 30% of patients. Reducing the dose negated the side effects, but there is recent data to show that starting at a lower dose of 15 or 30 milligram might even not attain the remissions, which is supposed to be at 45 milligram once a day. So with these available TKIs, how do we choose which patient to offer which TKI? So it depends on several factors. One is the age of the patient, the CML risk score, the efficacy of the TKI, TFR goals, cost, and the patient comorbidities. So as mentioned by Dr. Ganesh, the risk stratification of a patient at baseline is very important. And the classical one is the SOCAL risk scoring, which still stands in the time of imatinib, but the ELTS score is now coming up in the ELN 2020 guidelines as the best risk stratification ahead. So what's the importance of risk scoring? If the patient is categorized as a low risk, it is safe to start on imatinib. Intermediate risk patients can be offered imatinib or a second generation TKI, and high risk patients, you should strongly consider a second generation TKI. The NCCN guidelines slightly varies in say that high-risk patients should be offered second generation TKIs. So if you look at the efficacy of the TKIs in the first-line treatment, what is important is that although the second generation TKIs attains a higher or earlier rates of early molecular response or MMR, at a long-term follow-up, the effect on PFS or the progression-free survival and overall survival is not much, and it's comparable to Imatinib. Second generation TKIs definitely scores over Imatinib in terms of attaining an MR4 or MR4.5, which is important when you consider TFR trials in a patient. So summarizing, the second generation TKIs attains a higher rates of complete cytogenetic response or a major molecular response, and it prevents or decreases the progression towards an accelerated phase or a blast crisis. So what are the side effect profiles of the TKIs which require dose adjustments or selection of patients? So common side effects of all TKIs include cytopenias, which is mainly the toxicity of the TKIs, and rash, nausea, muscle cramps, and edema. With regard to Imatinib, you can have severe muscle cramps which can interfere with the quality of life and even decrease in dose reductions. Specifically in relation to Nilotinib, the cardiovascular, the coronary cerebrovascular peripheral arterial diseases is a very serious side effect requiring dose reduction or even stopping the drug. Dasatinib, as mentioned, it causes pleuropericardial effusions, rarely pre-capillary pulmonary hypertension, and a prolonged QT interval. There have been cases of Dasatinib which presents or causes platelet dysfunction and leading to severe bleeding tendencies. Bosutinib is different from all the TKIs in that the side effect profile is different and it can be safely given in patients with cardiovascular toxicities. So if you compare the efficacy with the tolerability of a TKI, so if you look here, Imatinib 400 milligram once a day has a better tolerability, but in terms of efficacy, it stands behind the second generation TKIs. So this graph will help you roughly choose in terms of efficacy and tolerability as to which TKI to opt for in a particular patient. This is a side effect profile, and those marked in green, so Bosutinib, Dasatinib, and Imatinib can be safely used in patients who have these cardiovascular effects, whereas Nilotinib and Ponatinib are not generally advocated. What exactly we mean by the molecular response is based on the IA scale. If you have a baseline of 100, the 1 log reduction suggests BCR-ABL less than 10% and 2 log reduction BCR-ABL less than 1%. So an operational cure can be considered if attain an MR of 4 or 4.5. And the molecular responses, what does it translate into clinically? So the achievement of MMR is associated with a longer duration of cytogenetic response, higher rates of EFS and PFS, and an increased probability of achieving undetectable BCR-ABLs. And an early response to TKI therapy associates with a higher probability of attaining a future MMR and an MR 4.5, making a patient go into a TFR trial. So if you categorize the response according to the risk score, you can see that both Dasatinib, Bosutinib, Nilotinib all attains higher rates of MMR and MR 4.5. And what happens to the effect of this TKIs post-Imatinib resistance? You can see that still the attainment of complete hematologic response, major molecular response, and cytogenetic response are all better as compared to Imatinib, and 2-year PFS and the overall survival rates still stands good. One important factor when we think of resistance or intolerance to TKIs is adherence. So a WHO study estimates that only 50% of patients suffering from chronic diseases follow the recommended treatments, and Imatinib non-adherence is very widespread. From the Adagio study, which shows that less than 15% of patients are perfectly adherent to treatment. So does this have any effect on response? Yes, definitely. The major molecular response and the deep molecular response is definitely influenced by the adherence. Patients who are adherent to more than 90% of the dosage have a better MMR and DMR. So regarding age and TKI selection, we know that patients in India are come a decade earlier with diagnosis with CML. So they are more younger and a more life expectancy. So in these patients, they are ideal patients to go for a TFR so that they do not have the toxicities of the TKIs in the long run. The cost is a major factor in our setting, but now we have generics of Imatinib, Dasatinib, and Bosutinib. So therapy cost for a month, we can start with Imatinib, it's around 1,000. We have drugs which can start from 1,000 per month. Whereas Dasatinib and Bosutinib, it's slightly more costlier, ranging from 3,000 to 8,000 rupees per month. Nilotinib, still we don't have the generic available, still is the innovator Dasatinib. As mentioned, the TFR goal, this is the new standard in the ELN 2020 guidelines. And who are our high priority for TFR? One is the younger patients with low or intermediate risk disease and women who wish to become pregnant. Why? Because the second generation TKIs increase the depth of response, especially the early molecular response and the deep molecular response, and attaining a patient go into a TFR. How do we monitor the treatment response? There are surrogate markers like the MMR, which corresponds to the complete cytogenetic response. And it is important to understand that the molecular testing depends upon the laboratories and the techniques which we use, and it should be very well standardized. Bone marrow examination is recommended usually at baseline and not during follow-up because we have the surrogate markers. And FISH test can always be used in terms for assessing the cytogenetic response. So this is again the milestones in monitoring the ELN 2020. So if your patient, the ideal settings are attaining less than 10% BCR-ABL at 3 months and less than 1% BCR-ABL at 6 months. If it's anything more than 1%, it's a warning sign, or more than 10%, it's a failure and a recommendation to treat or change the therapy. So how does it affect as a second-line agent as compared to Dasatinib, Nilotinib, and Bosutinib? So if the first-line PFS rates are close to 90% at 5 years with Dasatinib, it is almost half. So if you take all the 3 second-generation TKIs together, the second-line PFS rates varies from somewhere around 40 to 60%. Whenever we think of changing the TKIs due to resistance or failure, it's always good to assess the mutation status because we can select particular TKIs based on the mutations available, and there are definite guidelines to do that. So coming to the case which we discussed earlier, so this was a young male who presented with priapism with a 3-month attaining the early molecular response, but at 6 months still in the warning phase. We try to follow this patient up, and 2 weeks later we repeated the qPCR, which was again at 12%. So that was a consideration for a failure of therapy. We needed to change the treatment. So we did a mutation analysis which didn't show any tyrosine kinase domain mutations. The marrow did not show any progression of disease at that point of time. We changed to Nilotinib 400 mg twice a day, but as per the patient, he didn't tolerate it poorly and the adherence was not good. 3 months after changing TKI, the qPCR did decrease from 12% to 1.2%, and the CBC at that time was normal. 2 weeks later, again, he presented with fever with pancytopenia. But at that point of time, the bone marrow and the flow cytometry was suggestive of a lymphoid blast crisis in a patient who had failed or did not attain the earlier response in a suggested setting. So concluding, the 4 available TKIs are approved in first-line treatment for CML chronic phase. Second-generation TKIs cause better and faster responses with no impact on survival as compared to Imatinib. And the TKI selection is based on several factors, most important of which are age, the disease characteristics, the comorbidities and the toxicities expected, the risk of the disease, and the cost factors. And when you select a TKI, doing a mutation status is very important. So at 2001, we had this magic bullet Imatinib which came into the picture. And now we are looking at a stage where we have to quit the TKIs for betterment. So science is definitely advancing and we are in a good. Thank you.
Thank you so much, Deepak. That was a very elaborative, presentation on how to choose the TKI upfront in our CML-CP patients. So what we will do, Dr. Deepak, we will share all the questions at the end of the session. Just to continue with the momentum, I will now request Dr. Prabhu to, as I mentioned you earlier, for those of you who have joined late, Dr. Prabhu is a senior consultant hematologist at Apollo Hospital, Chennai. And Dr. Prabhu is going to take the next talk on therapeutic efficacy and safety of Dasatinib in CML, and the long-term outcome. Over to you, Dr. Prabhu, please.
Yeah, just give me a moment. I'll just share my slides.
Yeah.
Hey. Madhu.
In the meantime, Dr. Deepak, your case very precisely elaborates, the patients with cytopenia and failing TKIs with very high qPCR levels. These are quite worrisome patients, and these are the subset of patients who are poor risk of all the TKI failed patients, and that signifies the possible exhaustion of leukemic stem cells. So here comes Dr. Prabhu. Over to you, Dr. Prabhu.
Yeah. Okay. Sorry about that slight delay. I think my role today is to talk to you about therapeutic efficacy and safety of Dasatinib in CML, and also focus at long-term outcomes in patients treated with Dasatinib in CML. Okay, as all of us know, Dasatinib is a second-generation tyrosine kinase inhibitor. It's a dual tyrosine kinase inhibitor with a greater potency than Imatinib. And of course, like several other second-generation tyrosine kinase inhibitor, it has given us another additional option, which has made treatment, which has helped us in achieving greater molecular remissions and also greater treatment successes. So I think I'll be very brief because both of my colleagues have gone through all of these trials to a certain extent. So the first trial to come out looking at efficacy of Dasatinib in CML was the Dasatinib trial. And in 2014, they reported 3-year results from the Dasatinib versus Imatinib Dasatinib trial. So what the initial 3-year report suggested was that one thing which was well established with this 3-year analysis was that patients who achieved better transcript reduction at 3 months had much better overall and progression-free survival. This curve clearly illustrates that whether you achieve that using Dasatinib or Imatinib, if you achieve BCR-ABL percentage of less than 10% at 3 months, you tend to do well. So this is the first thing that was established with this 3-month analysis of Dasatinib trial. So overall survival, again, compared to patients who achieve less than 10% BCR-ABL numbers compared to more than 10% was much better in both Dasatinib and in the Imatinib arm. If you look at major molecular remission at 36 months, Dasatinib at 100 milligram had higher MMR rate, MR 4.5 and MR4 rates compared to Imatinib. This was seen also across the as well. If you look at patients who discontinue treatment, what is becoming evident from this particular table is that there were fewer discontinuations in the Dasatinib arm compared to the Imatinib arm, and the progression fewer Dasatinib arm. If you look at adverse events, there was a slightly higher representation in the Dasatinib arm. That's most likely due to pleural effusion related issues. Again, the 6-month landmark analysis looking at patients who achieve BCR-ABL less than 10% compared to the ones who have BCR-ABL above 10%. There was much better patients who achieve BCR-ABL less than 10% have better progression-free survival, whether they achieve it with Imatinib or with Dasatinib. Again, in 12-month landmark analysis, that is borne out. So if you look at adverse events between Dasatinib and Imatinib, one thing that stands out is pleural effusion. So patients who received Dasatinib had a higher incidence of pleural effusion, whereas virtually there was no incidence of pleural effusion in the Imatinib arm. This is a peculiar side effect of Dasatinib, which one has to be aware of. other than pleural effusion, it appears from this trial that Dasatinib was very well tolerated. So what the initial analysis concluded was that first-line Dasatinib resulted in faster and deeper responses compared with Imatinib, and achievement of early molecular response was predictive of improved progression-free and overall survival, irrespective of whether you achieve with Dasatinib or Imatinib. And BCR-ABL transcript levels greater than 10% at 3 months is associated with worse outcomes. And what it also clearly concluded was that BCR-ABL transcript levels less than 1% at 6 months became a new prognostic threshold, and this was associated with reduced risk for transformation and a trend for better progression-free survival. So overall, the conclusion from this trial was that Dasatinib used as frontline therapy at 3 years induces faster and deeper cytogenetic and molecular responses, and overall translate into better outcomes. The data also supported that BCR-ABL transcript levels greater than 10% at 3 months was associated with worse outcomes, and a transcript level less than 1% at 6 months became a new prognostic threshold and was associated with reduced risk for transformation. So what it establishes is that although if you look subsequently, there is no big difference between overall survival and progression-free survival in both arms, but achieving early molecular response does confer some advantage in terms of reduced incidence of transformation in patients with CML. So Decision, again, 5-year analysis more or less confirmed everything that was found in the 3-year analysis of Decision trial. In the interest of time, because this has been looked at by both my earlier speakers, I'll be rather rapid with my presentation. So if you look at, I think I'll go to the, So this is an important slide with Decision 5-year analysis. What this slide shows is with progression of, as you go the x-axis, as time progresses, the number of patients who have achieved MMR with Dasatinib continue to be much higher than the ones who have achieved with Imatinib. Again, it's this slide also clearly shows that MR 4.5, as you follow these patients up in Decision trial, there's a higher achievement of MR 4.5 in the Dasatinib arm compared to the Imatinib arm. If you look at risk across the various risk scores, again, the incidence of MMR is higher with Dasatinib than Imatinib. So if you look at complete cytogenetic response in patients with Dasatinib 100 milligram once daily, this slide tells you again that BCR-ABL transcript levels less than 10%, whether you achieve with Imatinib or Dasatinib, translate into much higher CCR and MMR results. But if you look at overall survival in Decision, whether they received Dasatinib or Imatinib, irrespective of whether they achieved early molecular landmark or not, the overall survival and the progression-free survival continues to be very similar to each other. So what it tells you is that there is no big advantage between Dasatinib and Imatinib if you look at overall survival and progression-free survival. Again, this is a repetition of those two slides. So let's go to adverse events with Dasatinib. As I told, as we looked at in the initial slide, one adverse effect that stands out with Dasatinib is pleural effusion. Otherwise, most of that is one single adverse event which is very peculiar to Dasatinib. So Decision trial at 5-year analysis showed that Dasatinib, as compared with Imatinib, produces faster and deeper responses, but the progression-free survival and overall survival is as good as Imatinib. On follow-up for 5 years, there was no new safety signals except for higher incidence of pleural effusion. And what it concluded was that the first-line Dasatinib should be used as a standard first-line therapy, should be offered as a standard first-line therapy for patients with newly diagnosed CML's chronic phase. So there were a few other important landmark trials with which compared Dasatinib against Imatinib. This is a trial where there's a DASAN randomized study which looked at patients who have been on Imatinib who failed to achieve the 3-month landmark of achieving less than 10% BCR-ABL transcripts. The DASAN study, who was subsequently given Dasatinib, and this trial looked at the kind of response they had after receiving Dasatinib after failing to achieve less than 10% BCR-ABL transcript numbers. So this is a study design where 3 months, if your BCR-ABL is greater than 10%, you were randomized to either get Dasatinib 100 milligram OD or an increased dose of Imatinib. You could either continue the same dose or you were given an option of increasing the dose of Imatinib to 400 milligram BD. So if you look at major molecular response at 12 months, Dasatinib had 29% of patients on the Dasatinib arm had a higher MMR compared to patients who continued on Imatinib arm. If you look at major molecular response at 24 months, again, there was a slight increase in incidence of major molecular response in the Dasatinib arm compared to Imatinib arm. So this study just does tell you that there is some value in changing at 3 months from Imatinib to Dasatinib if you have not achieved your less than 10% BCR-ABL transcript numbers. But if you look at progression-free survival and overall survival in this trial, it's very similar. So this does raise some doubts about the strategy of changing from Imatinib to Dasatinib when we don't achieve less than 10% transcript numbers at 3 months. Again, this in this particular trial, when you considered overall survival and progression-free survival, whether you crossed over or not was very similar. So to conclude, in DASAN trial, there was early achievement of molecular responses, but it did not translate into better overall or progression-free survival when you switch to a newer TKI at 3 months. There have been several other trials which have looked at Dasatinib in the management of CML. In the interest of time, I think we shall not really look at them in any detail. But Dasatinib has been used in pediatric patients as well with very similar results as seen in Dasatinib. Of course, Dasatinib did not include pediatric patients. Okay, this is quite an interesting study which was from MD Anderson, I think, which looked at long-term follow-up of patients who received lower dose Dasatinib at 50 milligram once daily as frontline therapy in newly diagnosed chronic phase CML patients. So this looked at major molecular response rates over time in patients who have received either Dasatinib 50 milligram, but they included Dasatinib 100 and Imatinib from historic patients from the Dasatinib 100 milligram and the Imatinib arm was actually from the Dasatinib trial. So when compared to Dasatinib at 100 milligram and Imatinib, there was an early achievement of molecular response with Dasatinib 50 milligram. This is quite an important finding as it has major implication in terms of cost and side effect management with Dasatinib. So if you again look at various landmarks when you follow patients up with CML, like complete cytogenetic response, major molecular response, MR4, MR4.5, etc., with the 50 milligram lower dose Dasatinib arm, there is a significantly good significantly good achievement of various molecular landmarks. Again, this is Dasatinib 50 milligram overall survival, event-free survival, and freedom from progression. Overall survival and event-free survival again shows that Dasatinib 50 milligram is a useful dose, is a very effective dose to start with. So what is the advantage of low-dose Dasatinib? The safety profile of low-dose Dasatinib seems to be excellent. There seems to be less myelosuppression, and incidence of pleural effusion and pulmonary hypertension is lower compared to 100 milligram. When the side effect incidence of side effects is lower, it allows the uninterrupted use of Dasatinib, thereby probably increasing the efficacy of treatment. As we could see in the earlier graph where we looked at 100 milligram and 50 milligram, 50 milligram seemed to be outperforming 100 milligram dose. And of course, most importantly, 50 milligram is a cost-effective dose. So low-dose Dasatinib is much better compared to 100 milligram based on this single-arm study, and seems to be better tolerable and achieves major molecular landmarks fairly early on in the treatment. So when you look at safety of Dasatinib, when you consider Dasatinib, there are two important side effects that come to mind. One is pleural effusion and other is pulmonary hypertension. Pulmonary hypertension is not unique to Dasatinib. It can occur in other tyrosine kinase inhibitors as well, which is used in CML, but definitely there's a higher incidence in patients who have Dasatinib. There's a marginally higher incidence in patients who are given Dasatinib. So you will always have to be very vigilant about symptoms of pulmonary hypertension, which can take the form of just chest pain and breathlessness, and you need to really screen them with echo to look for pulmonary arterial pressures. One important aspect of this pulmonary hypertension that happens with Dasatinib is that it is reversible when you stop the medication. And once a patient on Dasatinib develops pulmonary hypertension, you need to permanently discontinue Dasatinib. But the incidences, if you look at, I can't recollect the exact figures, but if you look at Dasatinib, if you combine overall Dasatinib use across various trials, the incidence of pulmonary hypertension is extremely small. But however, it's an important complication to bear in mind. The second peculiar complication to Dasatinib is pleural effusion, which happens for example, in Dasatinib, the incidence of pleural effusion, either grade 1 or grade 4 toxicity, all put together was around 23 to 25%. But what was found was that pleural effusion is dose related. If you look at patients who've been on 140 milligram and 100 milligram, there was much higher pleural effusion in the higher dose. That's also borne in studies which looked at Dasatinib at 50 milligram. Patients who received Dasatinib at 50 milligram had lower incidence of pleural effusion. So how does one treat patients who develop pleural effusion? Very often, if it's a small effusion and there is no symptom relating to the effusion, just interruption of therapy for a few weeks should resolve the issue. But if the effusion is significant and causing breathlessness, you can use diuretics and also low-dose steroids, which you can quickly taper. Sometimes pleural effusion in patients with Dasatinib can recur, and you can manage them similarly, but if it becomes of nuisance value, then you'll have to change your tyrosine kinase inhibitor. So whenever you talk about any tyrosine kinase inhibitor, now it's becoming increasingly important to look at the treatment-free remission that one can achieve with these agents. So there are two important trials with Dasatinib, which which gives us some idea whether you can use Dasatinib as an agent to achieve treatment-free remission. So one is the DAS-free trial, where patients with Dasatinib treatment for more than 2 years who had durable molecular remission for more than 1 year prior to enrollment were advised to discontinue Dasatinib, and they were very closely monitored. So this graph tells you that if you look at months since discontinuation of Dasatinib, there is although there is initially a significant relapse resulting in a steep drop in the curve, but subsequently there is a flattening of the curve, which says that about 45 to 50% of patients after the initial 6 to 12 months of follow-up in DAS-free trial tend to maintain their molecular response in spite of not being on Dasatinib. So this again tells you the treatment-free remission at 2 years. So that is at 2 years, if you there's about 40 to 50% of patients who maintain their remission status without being on Dasatinib. So there's also another trial which looked at first-line Dasatinib, where patients have had first-line Dasatinib for about 2 years and have had a deep molecular remission. In them, Dasatinib was discontinued. And again, the treatment-free remission at 6 months was 55.2%. So basically what I've done today is to rapidly go through various trials that has established Dasatinib as a viable first-line option in CML. Just to summarize, all these trials show that in comparison to Imatinib, Dasatinib achieves molecular landmarks early, and early molecular landmarks does translate into durable remissions. So if you have durable remissions, you can hope for TFR. So that's why Dasatinib scores over first generation TKIs, and various various trials where they have discontinued Dasatinib have clearly shown that patients on discontinuation, 40 to 50% of patients who received Dasatinib either as first line or second line continue to maintain their remission. And one of the slides that I put hasn't come out. That was from DAS-free trial, where it showed that even the patients who do have molecular relapse quickly go into remission on restarting Dasatinib. So Dasatinib as first line is, although you may not see a big difference between Dasatinib and Imatinib in terms of progression-free and event-free survival, progression-free overall survival, it does help achieve. And I think important take-home point is also this single center study, which has shown Dasatinib 50 milligram as a very effective alternative to 100 milligram that helps us in terms of reducing cost of treatment. And if Dasatinib is going to help us achieve TFR, and if you can achieve it at a lower cost at a 50 milligram dose, all the more better. So with that, I'd like to conclude my talk. Thank you.
Thank you, Dr. Prabhu. That was a very elaborate presentation, emphasizing the rationale behind the second generation TKIs upfront. So with that, we conclude all the three talks. I think we can take questions, whatever have come on board. So one question to Dr. Prabhu from our team. So this is Dr. Nagesh from Nashik, Maharashtra. He says he is asking Dr. Prabhu details of Dasatinib for GIST, gastrointestinal stromal tumor, for second line, or those who have not tolerated Imatinib. Although this question is not pertinent to our session today, and most of the speakers are dedicated hematologists. So difficult to answer this question, but just while this question has come on board, Dr. Prabhu, you had anything to address?
See, I'm a pure hematologist. I do only hemato-oncology, so I really can't comment on GIST tumors.
Correct. So I just tried to inquire with one of my medical oncology colleagues. So the answer to this question is yes, Dasatinib can be used as a second line agent for GIST, where for those Imatinib refractory or intolerant patients. But then the responses are not very promising, but still it is a viable option for those patients. I hope this addresses Dr. Nagesh's question on board. So with that, we will proceed to the last part of today's webinar. That is a brief panel discussion, just to put before the audience the gist of all the talks of today, real life cases with where first second generation dilemma, that sequencing, how we can handle. So Dr. Prabhu, can you come out of your screen? I will start.
Oh yes, done.
Okay. So I hope my slide set is visible to everybody.
Yes.
Yes. So TKI selection and monitoring in our day-to-day practice for CML. So So before I start, I will just quickly put before this audience poll for those of you who are watching this webinar. I think there is a on the upper border there is a chat box. You can answer your you can put your answers on the chat box, and we'll come to know. So these are pertinent questions in our day-to-day practice, just to put the summary of all the three talks happened today. So the first question is, which of the following statement out of all the four is false? Number one is tyrosine kinase domain mutations are not needed at diagnosis. The TKI KD mutations should be done when a patient has failed or has a suboptimal response to the various TKIs the patient is taking. This kinase domain mutations are best done by Sanger sequencing, and the option D is current available assays detect 100% mutation in all the cases. So I think I will give 10 seconds for audience to put their answers in the chat box, and then we'll see the correct answer to this question is. The technical team, can we have the answers? I think 10 seconds are over. We will wait for another 5 seconds, and we can see how many of you are voted for which. Is the technical team on board?
Yeah, people have not responded yet on the
I think
audience poll.
Okay, I think the chat box thing is a little new to the audience, because most of the webinars, the audience poll is the button is the click button is right on the screen. So we'll proceed. I will answer this question. So basically, the option A is correct. We don't need kinase domain mutations at diagnosis. This is only done when a patient has failed or has suboptimal response to TKI, so that can help us the reason behind the TKI failure, and then also subsequent strategy for the choice of second line TKI. The option C is the wrong answer here. It is not best done by Sanger sequencing. The best one is NGS, next gen sequencing. And NGS, even though the KD domain mutations are not the reason for all the TKI failures, there are, as Dr. Deepak has nicely elaborated, there are other genomics which can underlie the failure of TKIs. Other genomic mutations are, other than KD mutations, which can be the reason for TKI failure. So this was a very nice paper published recently, a prospective assessment of NGS detectable mutations in CML patients with non-optimal response. So you can see this is next in CML study. You can see the left graph, you can see the mutations detected by Sanger sequencing 25% only, whereas the mutations by NGS almost double, 47%. And I guess remaining are the mutations picked up, the non-KD mutations, which need other assays. So basically, not only the number of mutations picked up by NGS are higher, but also the different combination of mutations as well as high and low level mutations all can be nicely picked up by NGS as elaborated in this paper. My next question was, so which of the following is the correct statement about treatment-free remission? So the option A is relapse rate is 20% while attempting TFR, irrespective of TKI first or second generation. Relapse risk is highest during first 2 years. Option B. Option C is almost 25% can progress to accelerated phase or blast crisis when attempting for TFR. And quantitative PCR for BCR ABL is required to be done every 3 to 6 months when you are attempting TFR. And the option is TKI withdrawal occurs in 10 to 30% patients. So I think the option E is correct here. So TKI withdrawal is typically seen in 10 to 30% patients. The option A is wrong. About the relapse rate is about 50 to 60% So about 40 to 50% patients in both first and second generation TKIs maintain the deeper molecular remission despite being off the drug. The relapse risk is highest during first 6 to 8 months, and not first 2 years. That's why the first 6 months, the stringent monitoring of monthly qPCR is mandatory as per the ELN criteria. So, and the option C is also wrong. About 25% can progress to accelerated phase and blast or blast crisis. In fact, that is the reason why we can safely attempt TFR if the patient fulfills the various prerequisites for TFR, because the risk of progression to accelerated phase is not higher than when compared to the patients who continues to be on various TKIs. So essentially the risk of progression is just under 1 to 2%, which is almost equal to while being on the TKI. And option D is also wrong. So qPCR for BCR-ABL is required every month for first 6 months, and then every 2 months for next 6 months, and then every 3 months. So option E is the correct one here. Now coming to my last question, which of the following is false about Dasatinib? The option A is starting dose is 100 milligram once daily for most patients. 50 milligrams is equivalent to 100 milligrams is option B. Option C is risk of pleural effusion or pulmonary hypertension is low with low dose, that is 50 milligrams. Accelerated phase or blast crisis progression risk is higher with 50 milligram, that is the lower dose than the conventional standard of care. And the option E is Dasatinib is preferred over Imatinib in ELTS intermediate and high risk group, as has been discussed at length during our 3 talks today. So starting dose still holds 100 milligram for most of our patients, unless and until there is a tolerability or associated comorbidity issues. Even though Dr. Prabhu has very nicely highlighted the recent MD Anderson paper where 50 mg in fact seems to be superior on a short-term follow-up of 1 year. But the data is still not yet mature, so we need to wait longer for the and this is this is a single center experience. So there are currently few prospective trials going on about the optimal Dasatinib dosages. So with regard to second generation TKI dosages, you can see both with Dasatinib, Nilotinib, Bosutinib, because they are very, very potent tyrosine kinase inhibitors compared to first generation Imatinib. The dosage is not standardized as of now. There are various trials who are trying to dose reduce to increase the tolerability without compromising efficacy. But time will tell us the exact, the most precise optimal dose for each of the second and third generation TKIs later. In fact, this year EHA and ASCO there was a presentation on Ponatinib optimal dose also. So in that preliminary results, the Ponatinib 50 milligrams, 15 milligrams, 30 milligrams, 45 milligrams are almost equal. So with regard to all second, third generation TKIs, the dose is not yet standardized. Time will tell us in near future. So as Dr. Prabhu has highlighted, 50 milligram is equivalent to 100 milligram, and yes, risk of the toxicity of Dasatinib is lower with low dose, that is 50 milligrams. And again, the option D is wrong. Even though the toxicity is low, efficacy is maintained, and the risk of progression has not been extraordinarily high when Dasatinib is dose reduced at 50 milligram as per the MD Anderson paper. Again, Dasatinib or any second generation TKI is preferred over Imatinib as per the NCCN 2020 guidelines in intermediate and high risk group. So with that, I will start my short panel discussion of 2 cases. This is a young girl, young medico. I recently happened to see her just a couple of months back. She's a 21-year internee from Gulbarga, only daughter of the family. So not only the patient and the disease and the comorbidity factors are important, but then their social and the family background is also carries equal weightage. She is CMLCP ELTS high risk group. come to you for a second opinion, has come to me for a second opinion about the frontline TKI. Elsewhere, she has been recommended Imatinib, which is also absolutely valid option. Mother is very anxious with a lot of concerns about her daughter's reproductive life ahead. The parents are planning her marriage soon, and then with the devastating news of blood cancer, with a requirement of lifelong anti-cancer medicine, they are quite concerned about the future, with more so with their married life of their daughter. So what's your choice in this context? I will start with Dr. Deepak.
Young female, high risk baseline, so better to start on second generation TKIs. That would be my first option. I'd advise second generation TKI, and I'm not sure she is a candidate for a TFR trial because baseline she is a high risk group. So most of the recommendations are like, if it is a low risk or an intermediate risk, that will be ideal candidate to go into a TFR trial.
Correct. So yes, so low and there was a paper in Blood as well as ASH couple of years back about the one of the criteria being low or intermediate risk only to try TFR, but then ELN 2020, if the patient fulfills the criteria, the mandatory as well as the optimal criteria, even the high risk group, particularly looking at this particular girl, can be tried provided the family and the patient is willing and are committed for the requisite monitoring and willing to be on TKI again in the event of any increase in the BCR levels on follow. Is Dr. Prabhu on board? Dr. Prabhu, you have is Dr. Prabhu on board? I think I can see him. Okay, well, so basically, as Dr. Deepak has correctly pointed out, the previous dilemma of the ELTS high risk or various prognostic score high risk group, the question of attempting TFR or not in them is partly sorted out through this ELN 2020 guidelines. So coming to this, so after extensive discussion, counseling, and the toxicity as well as the efficacy, all these points were in depth elaborated with the family, and she opted for Dasatinib. So we started her on Dasatinib 100 milligram, which is a standard recommended dose once daily. But within two weeks of starting on Dasatinib, she complains of severe intolerable myalgia and recurrent epistaxis. What next? Dr. Prabhu, will you like to take this question? Will you like to take this case, Dr. Prabhu?
Hello.
Yes, Dr.
Hello.
Prabhu.
Hello.
Hello. Yes, Dr. Prabhu,
Hello.
you're audible. Please go ahead.
Hello.
I think we might have lost him. Dr. Deepak, what is your take on this?
So with this side effects happening, the best option, because we have enough data to show that Dasatinib 50 it may be as equivalent as 100. So it is worth trying, reduce the dose and see whether she tolerates. And if she still not tolerates, better would be to switch over to another TKI based on the tolerance. So I would go ahead with try to reduce the dose to 50 mg a day.
Okay, I think, okay. So just 1 minute. I think my internet Dr. Kunal, am I audible?
Yeah, you are audible. I was also got lost, so I reconnected. Looks like that Dr. Prabhu also had the same thing. Please, you continue.
So as Dr. Deepar has
Yeah, Dr.
elaborated
Prabhu has
and
joined. Dr. Prabhu has joined.
Dr. Prabhu, you want to, you have any difference of opinion here? So she is a 21-year girl, ELTS high risk group, and she is a medico internee with single daughter of the family. With the family has a lot of concerns about her immediate future. She is planning for marriage. She's the mother and father are very much concerned about her married life as well as reproductive life. So your
Hello.
choice. Yes,
Yeah.
Dr. Prabhu.
Solunga. Yeah, there is.
Okay.
No, just
So,
telling. I'm not able to listen to him, or I'm not able to see anything. I mean, I can see him, but it's just stuck in one page. So, okay. Anyway, I'll try to reconnect again. Yeah. Okay. Yeah.
I think Dr. Prabhu is frozen. So we'll move out to our second case. This is a lady, 48 years, from Telangana, Warangal, with no comorbidities. She presents to me in 2016 February. She is ELTS low risk group, and she is diagnosed. She was diagnosed at that time. And what would have been your choice, Dr. Deepak, at that time? Provided you had the option of all the second generation TKIs, which we the privilege of which we have now.
Okay. I would still go ahead with Imatinib, conventional dose of 400 milligram a day.
Yes. So whether the first or second generation TKI dilemma for low risk group is still not solved. It is partially the preference is inclined towards the second generation TKIs with regard to intermediate and high risk group as per the various guidelines. But for low risk group, and particularly even though I projected a paper which highlighted the preference across 100 plus expert hematologists from Europe for low risk group. Even for her age, 48 years, the opinion was 50-50, 50% opting for Imatinib and 50% opting for second generation TKI. But still, these are the dilemmas. But then if the patient is committed and wants emphasizes more on TFR, then I will be inclined to start upfront second generation TKI. But then patient has concerns about the drug, which is easy to go whatever length of time, then I will be inclined to start Imatinib. So at that time we didn't have choice. So we started her on generic Imatinib 400 milligram once daily, and this was her follow-up monitoring PCR. So the qPCR at 6 months was 6.3%, and at 12 months it was more than 1%, as Dr. Prabhu highlighted in his talk. More than 1%, it was 2.4%. Dr. Prabhu,
Ganesh, I'm really sorry. I just completely lost.
Yeah.
The connection. So I kept repeatedly trying to come. Anyway, I'm now back. I don't know much.
It has happened to all of us. So there was a period all of us were frozen. So Dr. Prabhu, your insight on your opinion on this case, who has been ELTS low risk group, no comorbidities, 48-year lady, and on follow-up PCR 6 months 6.3%, 12 months 2.4%.
Okay, so obviously at 6 months she has been less than 10%, but at 12 months we would have liked the PCR to be lower than what it is. PCR of 1%, less than 1%, translates into a complete cytogenetic response. So this is not a good situation for her to be in. So this is a time to change her medication from her generic Imatinib to possibly a second-line TKI.
Yes. So what will be your preference looking at her age, her comorbidity status, and this particular patient?
So she's a 48-year-old female. no comorbidities at all.
Yes, no comorbidities.
Yeah,
It's
she's a
normotensive,
48-year-old female with no comorbidities at all. Correct. Yeah. So she's a 48-year-old lady with absolutely no comorbidities. So we have, in terms of what we can choose either Dasatinib, Nilotinib, or Bosutinib. But in this particular situation, my choice generally would be Dasatinib, simply because although there are no comorbidities, it scores over in terms of ease of use. It's a once daily preparation compared to Nilotinib, which is twice daily, and you will have to, your food habits have to be altered according to the time you take the medications and things like that. So although you could choose any of the second line TKI, in this particular patient, I would prefer to choose Dasatinib. And generally, with all these trials showing a high incidence of arterial occlusive disease, etc., with Nilotinib, maybe Dasatinib is the right second generation TKI in this particular lady.
So, will you like to do any workup? Will you like to do any workup before switching over to second generation TKI? So, just for the sake of audience understanding.
Yeah, I think you need to find out if there is a mutation analysis. I mean, if there is a mutation present in the tyrosine kinase domain, which will guide us as to which tyrosine kinase inhibitor that you can choose. So you have to do a tyrosine kinase domain mutation. Some experts advise at this point to also do bone marrow aspirate and send it for cytogenetics. But definitely you need to look at tyrosine kinase domain mutations.
Yes, yes, Dr. Prabhu, as you correctly mentioned, even bone marrow evaluation to see if the patient has a clonal evolution and additional cytogenetic abnormalities, which has been highlighted in ELN 2020 paper. So, at any point of suboptimal response failure or the clinical evidence of disease progression, not only the KD mutation analysis, but also because many a times, as I highlighted before, the KD mutations are responsible for suboptimal response or TKI failure in 50% cases. 50% cases, there are genomic alterations or clonal evaluation which we can attempt to understand through bone marrow evaluation as well as the genetic profile. So as Dr. Prabhu has highlighted and also Dr. Deepak has mentioned and elaborated in his talk, this is the the TKI monitoring chart nomogram. You can see for a better understanding, you can see the patients with BCR-ABL more than 10% at 3 months. They are the one who are, we can label them an failure, and we can switch over to the next TKI as early as 3 to 6 months as per this chart. So red bar is the failure, the criteria to label that TKI has failed, and the the indication to switch over the next best available TKI. Green bar is optimal response, and yellow bar is to be alarming signal and needs close monitoring in subsequent 3-month PCR. If the levels are continuously same or worsening, then that fulfill the criteria of failure. So in our case, as we discussed earlier, we did so this is the various mutations, KD mutations, and the utility of various first, second gen and third generation TKIs against various KD mutation profiles. So in our case, she was positive for E255V, for which Imatinib has failed. Dasatinib also unlikely to work, and this mutation is also resistant to Nilotinib. And based on her profile, we started her on Dasatinib. And this is again a very important tool. The probability of response to subsequent second generation TKIs, a score published in Hematologica 2010. And as we were discussing, as per the Dr. Deepak's case in the first presentation, those having recurrent cytopenias and high risk so-called score, and based on their cytogenetic response to Imatinib, as in Deepak's case, the patient has a very high qPCR levels, has cytopenias and high Sokal score, and their probability, so this as per the score falls into poor risk group. Response rate to subsequent second generation TKIs is only 21%, whereas those having score less than 1.5, that means a good cytogenetic response previously to Imatinib, but not fulfilling the criteria of optimal response, low intermediate Sokal score, and not having history of recurrent cytopenias, they fall into good risk group, and these patients might have a very high probability of successful response to subsequent second line TKIs. So this is very important. So various factors needs to be taken into consideration before jumping on to subsequent second or third generation TKIs. And if patient has a very poor risk, this is the time point when you should also parallelly start working up for possible allogenic stem cell transplant, because those falling into this kind of probability high risk probability scores, their response being quite dismal, better to be prepared before they progress to various advanced stages. So also, so this patient was started on Dasatinib as per her KD mutation profile. She achieves MR 4.5, deep molecular remission at 2 years. However, at third year of follow-up, that was last year, she develops symptomatic pleural effusion while she's on Dasatinib 100 milligram. So I'll start with Dr. Deepak. How are you going to manage this lady?
Since she has attained a good response with Dasatinib, that to an MR 4.5, and this side effect which can be managed, trial of management with diuretics or steroids. I'll give a trial of steroids and diuretics and see whether this settles. And if she improves, I'd like to restart on a lower dose of Dasatinib.
Hello.
Yes, Dr. Prabhu, you are audible. Hello. So that is true, Dr. Deepak. So what exactly we managed with symptomatically with steroids, diuretics. In fact, we did pleurocentesis for symptomatic significant pleural effusion, and she recovered over next 1.5 months. And she was off Dasatinib during this period, of course. So how are you going to manage further, Dr. Deepak?
So I would definitely give a trial of re-challenge, but at a lower dose of Dasatinib, because there is MD Anderson data to show that these side effects are lesser at a lower dose of Dasatinib, and the same response most of the time can be maintained. So I'll be giving 50 mg.
Yes, Dr. Deepak. 50 mg. That is also valid this thing, and there is also a very innovative idea, even with if patient is not able to tolerate even the low dose 50 milligrams, so you want to continue 100 milligram with having achieved such nice milestones. So there is another strategy is that the intermittent off the drug period, that is 5+2 regime, and this is being evaluated prospectively by a German CML group in the Dasatinib trial. So this is 5+2 regime, wherein the drug is given for 5 days and weekends are off the drug, because Dasatinib has a very short T half-life. So the half-life is around 4 hours. So you don't need the continuous TRO levels. But then with this drug-free regimen of 5+2, 2 days being off the drug, the off-target activity can be significantly reduced, and you can see the hematological toxicity as well as the fluid retention. The CD is the continuous dosing and the ID is the intermittent dosing. You can see the fluid retention drastically comes down almost to the negligible level. So this is another important strategy. There was a paper also this time at EHA 2020 about this Dasatinib preliminary results, so which looks quite promising without compromising the efficacy. So she was started on 50 milligram Dasatinib, achieves MR 4.5 for last 1 year without recurrent PE or pulmonary hypertension. So she is 3 years of deep molecular response. So Dr. Deepak, is she a candidate for TFR?
Yeah, I would think so. Definitely.
Dr. Prabhu? Dr. Prabhu? I think we have lost Dr. Prabhu. So it was a wonderful discussion. Thank you, Dr. Deepak, Dr. Prabhu, and the Panacea Biotech for a wonderful, discussion on CML. And as I mentioned you earlier, CML it continues to amaze us, surprise us with a lot of new things coming up. And despite the surge of webinars on CML, I hope and I'm sure we might have learned something new in the field of CML. With that, I will conclude this webinar. I thank all the viewers, the Panacea Biotech team, and especially Dr. Deepak and Dr. Prabhu for sparing their valuable time and giving us valuable insights in the CML management in the current era. Thank you so much. And I conclude with an appeal to keep safe, all of you, by social distancing and appropriate uses of all the PPEs there. Thank you.
Yeah,
Dr.
on behalf
Prabhu,
of yes, on behalf of Panacea Biotech, we thank you, the panel, Dr. Ganesh, for nicely moderating it with your own presentation on the guidelines and which guidelines we need to use it from 2013 and 2020. Dr. Deepak has enlightened us amongst the what is the best TKI to choose. Yes, we are in the era of Imatinib followed by the Dasatinib. For Indian patient across the therapy area, cost matters a lot for continuation. Second thing is that adherence is directly related with the efficacy. And after Imatinib, Dasatinib has really the Indian generics or the generics are equivalent, which has really made us the affordability and continuing the medications for the long. Dr. Prabhu has really enlightened us, and your case presentation has made us that what is the Western data and what is the data of our patients. Panacea Biotech is there forefront with you with the generic of nano albumin bound paclitaxel Paclitaxel 2011, which has reduced the cost less than 50% for the metastatic breast cancer. Followed by that, we are in the forefront to get associated in the fight against the cancer, importantly blood cancer, with the Dasatinib, Dasapan. We look forward more of the interaction in terms of clinical research, patients monitoring, and working with you all to fight against CML. The new era has come up that about the TFR, and now you have selected the patient's cases where the weekend free treatment regime you are going to apply. And this is the newer innovations you are contributing in the CML management. We are there with you, doctor. So we thanks you all, and thanks to all our audience, the safe time and safe practice and taking care of all our patients in the new life during COVID pandemic. And I conclude this session on behalf of Panacea Biotech. Thank you very much.
thank you.
Thank you.
Thank you all. Thank you, Deepak. Okay. Dr.